They're all gone? Too cold? You're just talking about the weather. In any event, Dr. Leder is tied up at the VA Medical Center, and I haven't had a chance to look over the newspaper or do a little search to find out what of interest happened this week. So I have absolutely nothing interesting to tell you other than to introduce our speaker. So our speaker is Dr. Lisal Folsom, who joined the University of Louisville Faculty 217, and she is an assistant professor of pediatrics and internal medicine in the Division of Endocrinology, Metabolism, and Diabetes. And she began her career at Loma Linda Medical School and did a combined residency in pediatrics and medicine at the Medical University of South Carolina, and then moved to IU and the Riley Hospital, where she trained in endocrinology at both adult and pediatric. So the concept of the transfer of patient care between pediatricians and adult providers is a new field, and it's really growing, and it's certainly applicable to endocrinology and applicable to probably most of the other medical fields as well. So, for example, in our field, the care of patients with type 1 diabetes, those who have Turner syndrome, those who have congenital adrenal hyperplasia, it's often interrupted between the pediatric and adult caregivers. And in fact, I found that the individuals who are between age 18 and 25 have the worst hemoglobin A1C with type 1 diabetics, among type 1 diabetics, and they have the highest rate of hospitalization for ketoacidosis. So in addition to that transition group, there are many diseases that have their onset during adolescence, lots of immune diseases, in our field, Hashimoto's thyroiditis. So these are all areas for opportunities in academic medicine for both patient care and research. So another area of transition is obesity. So adolescent obesity rates have soared, and obese adolescents are at substantial risk for becoming obese adults. So Dr. Folsom, a vegetarian and an avid runner, today is going to talk with us about food obsessed and investigation in today's trendiest diets. Thank you.
Good morning. Thanks so much for coming out. It's a little chilly out there, so I'm glad to see so many people here so early in the morning. I wanted to thank everyone for coming out, as well as Dr. Winters for that very lovely welcome and introduction. Today, I am very excited to share with all of you about a topic that I am very interested in, and I imagine many of you are as well. That is food. We all love food. We all love talking about food and eating food, but even more importantly, food is an integral part of medical care and health. And I think that as medical providers, it's very important for us to know what's going on out there in the world, what our patients may be looking at in regards to research and different diet types, and how to intelligently make recommendations to our patients. So let us get started. I have no disclosures today. And over the next 45 to 50 minutes or so, we'll be talking about 4 main objectives. And my goal is that by the end of our time together, we will have reviewed the physiology of energy metabolism, what exactly is going on in the process of dieting, food consumption, and weight loss. We'll talk about the specifics of several current popular diets that people in the US are following today. We'll analyze the existing evidence in regards to those specific diets. So what are some of the health outcomes that we can expect to see? And then finally, we will develop strategies to assist our patients in regards to appropriate evidence-based clinical recommendations moving forward. So why are diets so popular right now in the US? I feel like every day we learn about something new, whether it was the Atkins diet many years ago, the ketogenic diet, the paleo diet, and one of the reasons is this picture that we all are intimately familiar with. This is the obesity map of the US from 2018, and we can see that we are not a small country. So here we are in Kentucky, And we have one of the maybe not so beneficial aspects of being at the very top of the obesity map. Over 35% of the residents in our state are obese. And I think one reason that diets are so popular is that we have this obesity epidemic in the US, and people are trying not to be obese. So why diets? I think as opposed to just not eating certain things, portion control, exercising, people are interested in diets because it's a specific prescribed plan. You don't have to worry about what you are or are not supposed to do because someone tells it to us. So there are a lot of different diets out there. There are diets that restrict certain types of food. There are diets that recommend certain types of food. There are diets that help you burn all of your fat all of the time. There are recommendations about carbs. Should you eat carbs? Should you not eat carbs? What carbs should you eat? What carbs are out there? What is a carb? There are diets that kind of restrict not the types of foods, but the timing that you eat your foods. And then there are all sorts of other brand name diets like MetaFast and Weight Watchers. So there are a variety of diets out there that patients and the population can choose from. But the question is, which one is best, right? So we will talk about that. So who is dieting? And I think in the US, we're a society where we're very dependent on social media and celebrity figures to kind of tell us what to do and what's popular. So Beyonce is a celebrity who has been very strongly a proponent of vegan and raw foods eating. Oprah has, lost weight on multiple different diets, but she was able to become a spokesperson for Weight Watchers because of the amount of weight she had lost on this diet. But maybe you're not a fan of Beyonce or Oprah. Maybe you're more of a sports person. And so Kobe Bryant maybe is your celebrity guru, and he follows the paleo diet sometimes. Taylor Swift will on and off follow a raw foods diet, and Lady Gaga follows a diet called the 5-factor diet, where every meal she includes 5 different components of nutrition into her plan. So these are people that, the US is relying on for dietary advice. But maybe that's not what we should be doing. We're healthcare providers, we're physicians, we are scientists, so maybe we should think about how we can apply this to our lives and our practice. So instead of listening to Beyonce and Taylor Swift, whom I very much enjoy, let's talk about someone else that really influenced my decision to learn a little bit more about nutrition and dieting. And this is one of my clinic patients. He's a 28-year-old guy. He's got type 1 diabetes, and he came in for his routine diabetes visit. We got to talking about his health regimen. He says, I'm checking my blood sugar 3 to 5 times a day. He's on a multiple daily injection insulin regimen with long-acting and short-acting insulin. He tells me that he's pretty adherent to his treatment plan. He never misses any of his insulin doses. He's very active. He enjoys hiking with his wife and his dogs. And then I asked him, what are you doing with your nutrition? What sort of eating plan are you following? And he says, I'm following the all-day fat-burning diet. And so being, his physician, I'm like, okay, tell me more about this all-day fat-burning diet. But on the inside, I'm sort of going like this because I realize I have no idea what the all-day fat-burning diet is and how is this going to influence his diabetes and his blood sugars and his insulin regimen. Is it good for him? Is it bad for him? And he's asking my advice, and I don't know what to tell him. And I feel like that this is really the important reason we should know about nutrition is because our patients are following these dietary plans and recommendations. And in order for us to counsel them in any sort of intelligent manner, we need to know what they're doing. So where do we learn? If we Google the best diets of 2019, you can see there's about 90 million hits. That's a lot of information for us to review. And so there's no lack of information, but how do we figure out what the meat is of all of our diet recommendations? If we look at the CBS News and US News and World Report, they tell us what the most popular diets are right now, what is trending. And I've chosen 4 that I wanted to talk about today, including the ketogenic diet, the paleo diet, intermittent fasting, and then plant-based eating. So we'll talk about each of these in turn. But first, we need to talk a little bit about what's going on with eating. What is the physiology of energy metabolism? Thinking back many years ago, we all took physics. And the first law of thermodynamics is that energy in equals energy out. And that's the basic concept of dieting. If we look at this first section up here, if you put more energy into your body than you expend, you will gain weight because the energy has to go somewhere and we store it as fat and more of our bodies. If we're equal, if we put the same amount of energy in as we burn, then our weight remains stable. And, which is the goal of dieting, if you put less energy into your body than we expend, we will lose weight. And so this is the first law of thermodynamics. So how do we put energy into our bodies? There is one way that we can get energy into our body, is not as with food. So you put food in, energy has gone in. Energy out is broken down into 3 different components. The first of which is our basal metabolic rate, and this makes up about 50 to 70% of all the energy that we expend. It is mostly determined by genetics. We can change it a little bit based on lean body mass. If we're able to build more, if we exercise a little bit more, it may change a bit, but this really isn't where the focus should be if we're working on expending more energy. We also burn energy with physical activity, and this is both just our daily activities, getting up and walking to the car, walking to lunch, just regular things that we do, but also exercise, so going to the gym, going to yoga, going for a run. These are ways we can expend energy. And this can be between 10 and 50% of our energy out, and so this is really where we can affect how much energy we burn. The third way we burn energy is through the thermal effect of food, and this is about 5 to 10%, and this is the amount of energy we use to process the food that we eat. You cannot eat more food to increase your thermal energy expenditure, so this does not be a good way to change, and that's also pretty much determined at baseline, and we can't change it. So energy in is food. The way to increase our energy out is really by increasing physical activity. So energy in, let's talk a little bit about the macronutrients. Carbohydrates, your breads, your protein, or your breads and your grains and your pastas. Fruits and vegetables also have carbohydrates. Proteins are typically thought of as things like meats, cheeses, milk, but there are also proteins in nuts and seeds and eggs. And then fats, your oils, also seeds and nuts. So we'll talk a little bit about these and how they contribute to our energy metabolism, as well as how they play into popular diets in the US. Carbohydrates have about 4.1 calories per gram as far as calories per weight. And there's no absolute daily requirement of carbohydrates that we need as humans. We could eat 10 grams of carbs per day. We could eat 10,000 grams of carbs per day. There's no absolute requirement for optimal health that we've been able to determine. We store carbohydrates in 2 main places, our liver and in our skeletal muscle. And our liver can store about 500 calories of carbohydrates in the form of glycogen. We have more skeletal muscle than we have liver, and so skeletal muscle can store more, right about almost 2,500 calories. So overall, we have about 3,000 calories worth of glycogen stored in our liver and our muscles at any given time. Proteins are about the same as far as caloric intake per gram as carbohydrates, 4.3 per gram. And about 14% of the average human stores protein. About 20,000 calories of protein is stored in our muscles. In starvation, we burn protein about 15%. So 15% of all the energy that we get in a starvation state is from the breakdown of protein. And there is a protein requirement in contrast to carbohydrates. Most adults need about 0.8 grams per kilogram of body weight of protein. Adolescents need a little bit more. And then there are certain states of physiology where we need even more, between 1.2 and 1.4 grams per kilogram of body weight. States such as pregnancy, young children, post-surgical state, and then athletes will need a little bit more protein. And then finally, fats. Fats have more than twice as many calories per gram as proteins and carbohydrates. So you could eat a gram of carbohydrate, a gram of protein, and still have less calories than a gram of fat. So heavy hitter. About 20% of the average human is composed of fat. That's about almost 132,000 calories of fat in our bodies. And if we wanted to use it all up, if we wanted to follow the all-day fat-burning diet and burn up all of our fat, we would have to be all-day fat-burning dieting for 63 days without any caloric intake. So that is a very long time. and that our fat stores are unlimited. Carbohydrate can only be stored in the liver and the skeletal muscle, and there's a maximum amount we can store. Same thing with proteins, but fats, you can have unlimited fat stores. You can have unlimited adipocytes. They can get as big as they want. So this is definitely something to keep an eye on when we're thinking about energy consumption and energy out. So in dieting, we're upsetting that balance. Think back to the picture of the scales where energy in and energy out were not equal. And that's what we're aiming for if we're thinking about weight loss in regards to dieting. So what is happening in our physiology in that fasting and that starvation state? If we are not eating, then all of the energy that we are putting out is coming from our body stores. We talked about stores. We have glycogen and skeletal muscle, and we have fat stores. So all of our energy is coming from our body itself. In the first about day and a half of fasting, no energy in at all, we're using glycogen. We're using that stored energy in our liver and in our skeletal muscle to make energy. But that's all burned up in about a day and a half. And then we do not switch to fat right away. We actually switch to protein. We start the process of gluconeogenesis in the liver, and we start breaking down proteins and amino acids. And that's what makes that detectable ketone level in the urine for people who are following the ketogenic diet very closely. We do this for about a week and a half. So we're not really burning much fat unless you have been fasting entirely for a week and a half. After that, you've burned up most of the protein that's easily accessible, and then we move on to fat. And as we mentioned, it's gone in 63 days. So you can go for a very long time without eating because we have so many fat stores. But it's difficult to access that fat even in a dieting state because you have that glycogen and that protein that's accessed first. So now we know a little bit about energy in, energy out, energy metabolism. We know a little bit about the macronutrients and what's going on when we're dieting. And so before we get too far into the specific diets, we have to think about them in regards of outcomes. Are we just interested in weight loss? I feel like a lot of times that's what people ask when they ask about opinions for dieting. What's the best diet for weight loss? What's going to get me down to my, my high school bikini weight? But as medical providers, we care about that, but we care about that because it affects health outcomes. Things like cardiovascular risk, things like insulin resistance and glucose metabolism, and risk for diabetes. And of course, we want our patients to live as long and as healthy as possible. So what is the evidence about mortality as well? So we'll talk about those popular diets in regards to these specific outcomes, keeping them in mind. So when a patient says, I am following the ketogenic diet, what does that actually mean? And the ketogenic diet is defined as no more than 50 grams of carbohydrates per day. Thinking back, we know that there's about 4 calories per gram of carbohydrates, and so that's 200 or so calories from carbohydrates a day, which is not a whole lot. The rest of that comes from non-carbohydrate containing foods. The rationale for the keto diet is that if you eat less carbs, your pancreas will make less insulin. And then you'll shift towards that protein catabolism state maybe a little bit sooner. And then you'll use ketones for fuel instead of the glucose that you eat. And so the idea is that if you can kind of accelerate that state of ketosis, weight loss will occur. So in the ketogenic diet, fats and oils are recommended liberally. You can eat as many of them as you want, things like avocados and plant-based oils and butter and heavy cream. Proteins like beef and fish and dark meats and nuts and seeds are all recommended. Cheese is good. Leafy dark green vegetables are also recommended. Occasionally, you can have some carb-containing vegetables, maybe like some zucchini or some yellow squash, but never should anyone have anything sweetened, dried fruits, milks, potatoes, corns, breads, or pasta. So some of the things that some people like to eat, they are not supposed to have on this diet. So what would this look like? What is a patient doing when they're following the ketogenic diet? Well, for breakfast, maybe some eggs and bacon, fried in oil, and some sauteed greens. Maybe they would have, so this is an interesting snack that's very popular in the ketogenic world where they take seaweed strips and wrap it around cheese. So that's a low carb snack. Lunch, maybe tomatoes stuffed with tuna salad. Maybe they'd have some turkey jerky for another snack. And then dinner, maybe some broiled fish with sautéed asparagus. So not bad, right? You could do this. You could do this for a while. So what do we mean by paleo? The paleo diet is based on the presumed diet of Paleolithic humans, so hunter and gatherers, people who did not have a garden, people who did not raise animals, people who just kind of foraged and ate what they could find. The rationale for this is that our genetics, our DNA, stopped evolving in the Stone Age. And so the idea is that we are not equipped genetically, physiologically, to process some of the foods that we typically eat in 2019. Things like fast food, things like processed anything, things like candy. And so the idea is that going back to the basics that we ate, quote unquote, millions and millions of years ago may be more healthy for us overall. If one were to follow the paleo diet plan, you could have vegetables and fruits and fish and meats and poultry and eggs and mushrooms and roots and nuts and seeds and water, basically anything that you could find if you were out foraging and hunting. The things that you couldn't have are grains, cereals, legumes, dairy, refined sugar, salts, and processed oils. So anything that requires some sort of farming or growing or gardening. Well, what would this look like? What's a typical paleo diet day? Breakfast, bacon and eggs. Again, this time you could have an apple because you could pick that from a tree. Lunch, maybe meat wrapped in a lettuce leaf and some raw vegetables because no bread on the paleo diet. Dinner, baked salmon with roasted vegetables, and snacks, you could have nuts and raw vegetables and fruit. So again, not bad. This is something that you could follow potentially. And then let's talk a little bit about intermittent fasting. In contrast to the two previous diet plans that we discussed, intermittent fasting is not a diet plan where you eat specific foods or specific foods are prohibited, but it's a time-restricted eating plan. And so this consists of periods where someone is fasting or not eating, alternating with periods where you eat potentially whatever you want. There are three main rationale for intermittent fasting. The first of which is that this is thought to be more in line with our circadian rhythm. We all have this biological circadian clock where during the daytime our bodies are reserved for specific tasks. So daytime is the time where we're awake, where we're eating, where we're creating energy and we're storing it. And then at nighttime, that's the fasting time period where we're accessing that energy that we've created. And so the idea with intermittent fasting is that we're mimicking this circadian rhythm through the way that we eat. The second is that our microbiome needs rest. There is some data in mice and animal models that show that animals who eat continuously tend to be more obese and have a less diverse microbiome in their intestinal flora compared with animals who are on an intermittent fasting plan. And then the third is that it's behavioral modification. If you have periods of time where you're not eating, that may translate into a total overall eating of less calories overall. There are different types of intermittent fasting depending on what plan you follow. There is complete alternate day fasting. This is the most hardcore part of intermittent fasting, where there are total days where a person does not eat, alternating with days where they do. So 24-hour periods of fasting. There's also modified alternate day fasting where the schedule is the same. There are still days where you eat and days where you quote unquote fast, but the fasting days you still eat a little bit, but severely restricted. So between 20 and 25% of the total calorie intake. There's also time-restricted eating, where instead of taking 24-hour periods of fasting, there are a certain time frame during the day that's designated for eating and designated for fasting. Maybe 8 hours a day is your eating time, and you could eat during that time, but then you would be fasting the rest of the time. One other type of intermittent fasting that I wanted to mention briefly is religious fasting, the most, I think, popular known as the practice of Ramadan. And this is where people are fasting intermittently, but not for weight loss or health outcomes, but for spiritual purposes. The reason I mention this is that a lot of the data, especially initially regards to intermittent fasting, was based on epidemiological observational studies of groups who were fasting for religious purposes. So what would this look like? Intermittent fasting, if we follow the alternate day regimen, you can see that up at the top on the x-axis are the days of the week, and the y-axis is the time of the day. During the green time periods, you can eat whatever you want, as much as you want, but then you alternate the green zone with the beige zone, and on the days that are beige, you would not eat anything at all. If you were following the time-restricted eating plan, you can see that it's set up the same, days of the week, time of day. We are fasting from midnight to 8 a.m., just like in the previous day, but then you extend the fast up until noon. During the green zone, you have those 8 hours where eating is permitted as much as you want, whenever you want. You could have brunch and dinner. You could have a big meal in the middle of the day. You could just graze all throughout that time period, but that 8 hours is your restricted time of eating. So we've talked about a couple diets. Which is best? And I think it's not a very good question because we don't know what we're asking. Which diet is best for what? For weight loss, for mortality. And I think that when we're discussing this topic amongst ourselves and with our patients, we have to say, what are our goals? Which diet is best for which outcome? And so keeping this in mind now, we'll shift gears a little bit and we'll talk about the health outcomes in regards to the diets that we've discussed. We'll talk about weight loss, of course. We'll talk also about cardiovascular risk. And we know that obesity is intimately related to insulin resistance and type 2 diabetes. So we'll talk about these as well. And then we'll also discuss mortality because who cares if you look good if you're dead, right? So before we get started, we have to take all of this data that I'm going to present with a grain of salt. It is very easy to do a dietary outcome study in a mouse because a mouse lives in a cage. And the food that the mouse eats is given to it. The exercise that the mouse does is prescribed for it. And you can watch every single detail of a mouse. When we do studies in humans, even perfectly designed, double-blinded, randomized controlled trials, humans are not predictable. Humans often do not do the things that we intend for them to do. Sometimes they do things we do not intend for them to do. And so even in the best of situation, there's a little bit of wiggle room as far as data interpretation. So we have to keep this in mind moving forward. Let's talk about weight loss in regards specifically to the ketogenic diet. What do the studies show? The best data that we have is a meta-analysis of 13 randomized controlled trials comparing the ketogenic diet to a variety of other types of diets. And all of the patients consumed the appropriate prescribed ketogenic diet consisting of less than 50 grams of carbs per day. And most of them used a low-fat diet. There were a few that used just traditional calorie restriction as well. And between these 13 studies, they contained between 26 and 307 participants. And they were followed for between 1 to 2 years. The results show that at 12 months, there was more weight loss in the ketogenic group. And you can see on this plot that it does seem to favor very low carb diets as far as weight loss. So this was really promising. If you follow a ketogenic diet compared to a weight loss diet, you lose more weight. However, when they looked at them at 24 months, the changes were no longer significant. So short-term weight loss, absolutely. Long-term weight loss, maybe not as much. Now, we really care about cardiovascular risk quite a bit because we don't want our patients to have heart attacks, MIs, need stents, and bypass surgery. Unfortunately, in regards to the ketogenic diet, there's no prospective data on acute cardiovascular events. We do not know if this diet plan is going to increase, decrease, or keep exactly the same your risk for any sort of cardiovascular event. But we do have some information on surrogate markers in regards to lipid profiles and blood pressure. The 13 randomized control trials that we discussed earlier show that on the ketogenic diet, most participants had an increase in LDL, but also an increase in HDL. So maybe they balance each other out. They also show that there was a decrease in triglycerides and diastolic blood pressure, and systolic blood pressure didn't really change much. So not super strong in regards to cardiovascular risk or even surrogate markers. What about insulin resistance and glucose intolerance? Remember, one of the rationale for the ketogenic diet is less carbs equal less insulin. So we would think that this would potentially be a very good thing. Mice data, remember what we said about mice, shows actual increase in insulin resistance, both in the whole body and in the liver specifically. So at least in mice, it doesn't really seem to play out. But mice are not the same as humans. And so we do need to look at that human data as well. And what the human data shows is that it depends on where you are at baseline in regards to what happens with insulin resistance and glucose intolerance. In healthy men who were studied, they, similar to the mice, showed an increase in total body and liver insulin resistance on the ketogenic diet. When they studied people with obesity, without any signs of insulin resistance or glucose intolerance, they found that at least in the short term, using euglycemic clamps, they had an improvement in insulin sensitivity. And when they looked at people with type 2 diabetes, they found that overall they had less glycemic variability, so less highs and lows, more stable glucose levels. At 56 weeks, they had an improvement in fasting glucose, but there was no change in the hemoglobin A1C. So their blood sugars were more stable, but not really a sustained improvement in overall diabetes control. And finally, mortality. Are we going to live longer if we follow a ketogenic diet? I don't know, because there's no evidence. There have not been any studies done on mortality in the ketogenic diet, so the jury is still out. Stay tuned. Let's move on to the paleo diet. Let's talk about weight loss with this nutrition plan. There have been 6 randomized controlled trials, so not as many as in the ketogenic diet research. And the paleo diet has been compared to Mediterranean dietary plans, a diabetes eating plan, and the national dietary guidelines as well in regards to efficacy. Between these trials, there have been 13 to 70 participants, and they've lasted from between 2 weeks to 2 years. And the overall outcomes show that there's no difference in weight loss between the groups. So everyone loses weight on a prescribed diet plan in the randomized controlled trials, but the people on the paleo diet didn't lose any more weight than those on the other dietary plans. So it's okay, but not better. In regards to cardiovascular risk, similarly to the data in the ketogenic diet, we don't have any prospective data on events. We don't know about myocardial infarctions. We don't know about angina. We just don't have the data. But we do have some surrogate markers. There have been 5 studies looking specifically at lipid profile and blood pressure. We have 1 pilot study and then 4 randomized controlled trials. And the studies have included between 9 to 70 participants. One lasted 1 day, up to 2 years. And they found overall an improvement in lipid profile on people following the paleo diet, and they had a decrease in blood pressure. So surrogate markers do seem like there's some promising evidence when we're following this paleo eating plan. And let's talk a little bit about insulin resistance and glucose intolerance on this plan. Those same 5 studies that we just talked about in regards to surrogate risk factors for cardiovascular risk also looked at glucose intolerance. The same number of participants, the same length of time that the studies were performed. And similarly to our data in the ketogenic diet, it depends on where you're starting from. In individuals who were noted to have a normal weight, they had an improved insulin sensitivity in one study, but in another study there was no change, so we don't really know. In people who had obesity, there was really no change in insulin sensitivity or glucose response. In people who had impaired glucose metabolism, they had an improvement in insulin sensitivity. And in people who already had type 2 diabetes, they did have an improvement in A1C, as opposed to those who followed the ketogenic diet where there was no change in A1C. So paleo seems like maybe there's some promising evidence towards glucose intolerance and insulin resistance, but I think the data that we have is based on a limited number of participants, and so some more information would be helpful. And mortality. In contrast to the ketogenic diet, we do have 1 study. It's a prospective observational study looking at mortality in people who followed the paleo diet, and they looked at a large group of people. Over 21,000 participants were analyzed, about 40% men, 60% women, and 2/3 of them were white. They followed the participants for 11 years, and during this time period, almost 12% of them died from causes of various determinations. When they compared those who were following a paleo-type eating plan with those who were not, they found that there was a 23% decrease in mortality rate, with a hazard ratio of 0.77. So this is pretty promising data. And when they split it up looking at different causes, they found that the ones that were less were cardiovascular death from cancer, and then death from non-injury accidents. So we do have a little bit of mortality data, and it does seem promising. With intermittent fasting, this is a newer type of eating plan, and so we don't have as much data, we don't have as many randomized controlled trials as we do for ketogenic diet and paleo diet. But let's talk about what we do have in regards to weight loss. There have been 5 randomized controlled trials, all looking at modified fasting regimens. So remember, those are where you're fasting kind of 20 to 25% of your energy requirements, alternating with typical eating days. There have also been 4 crossover trials looking specifically at time-restricted eating. So those are where you eat during a certain amount of time each day and then fast at the other hours of the day. They compared intermittent fasting both to traditional caloric restriction and to just regular eating habits. So they had people on a diet, people not on a diet, and compared this eating plan to both. The trials contained between 15 and 107 participants and lasted between 1 day to 6 months. And what they found were that 5 studies showed weight loss of between 3 to 8%. But remember, there are 9 studies, so that means that the other 4 didn't show weight loss. So I think maybe some promising data for future research, but not enough that we can recommend it wholeheartedly for weight loss. But what about cardiovascular risk? So again, we don't have any prospective data on events, but we do have a little bit of surrogate data. There have been 5 studies that have had comparison groups, and they've been able to compare individuals who were intermittently fasting to individuals who were not. 15 to 107 participants. They didn't look at blood pressure changes, but they did look at lipid profile. And what they found were that 5 of the studies, 5 of 7, showed no difference in the lipid profile between the groups. 1 showed increased triglycerides and increased HDL. 1 showed decreased triglycerides, and 1 showed decreased LDL. So I don't think that this is definitive, and I think we need a little bit more information before we can determine whether to recommend intermittent fasting to patients specifically interested in surrogate cardiovascular markers as their outcome. When we look at the insulin resistance and glucose intolerance data in regards to intermittent fasting, we do have 6 studies that have a comparison group, 15 to 107 participants. And if you weren't super impressed with the cardiovascular data, I'm very sorry, but I think this data is a little bit less convincing than that. 1 study showed a decrease in fasting glucose, and 2 showed a decrease in fasting insulin, but more of them showed no difference at all. So I think we just don't have the data to support using intermittent fasting if our outcome is insulin resistance and glucose intolerance. And mortality with intermittent fasting has only been popular for a little while, and so similarly to the ketogenic diet, we just don't have the evidence to support recommending this specifically for mortality. So, what do we know so far? We know that our rate of overweight and obesity in the US is 70.2%. We know we are a growing country. If we look at obesity specifically, it's almost 40%. So we know that this is something that we're struggling with as a country. We know, based on the first law of thermodynamics, that if we decrease our overall caloric intake, we will have weight loss. And I think we've reviewed that the ketogenic, paleo, and intermittent fasting diets are popular. People are doing them. But overall, I think we need a little bit more information before we can recommend them in regards to health outcomes for our patients. Weight loss, sure. But health outcomes, I think we need a little bit more. So what do we know? What's been proven to work? What's shown to be beneficial in regards to these outcomes that we just spoke about? We're going to talk a little bit about plant-based eating. The American Heart Association guidelines from this year recommend that patients have a variety of fruits and vegetables, whole grains, nuts, and legumes. The American Diabetes Association guidelines from this year also recommend some plant-based eating, emphasizing non-starchy vegetables, minimizing added sugars, refined grains, and choosing whole foods over highly processed foods. So this is good. if you're a cardiologist, if you're an endocrinologist, but what about those of us who are neither? USDA dietary guidelines that are current for right now also recommend plant-based eating. They say that we should have a variety of fruits and vegetables, at least half of our grains should be whole, and that less than 10% of our calories should come from sugary things. And I think it's important to make the distinction between plant-based and vegetarian and vegan eating plans. Plant-based just means that the basis of your nutrition is plants. So eating lots of fruits and vegetables doesn't mean you can't have a steak, right? It just means that you eat more plants than you do other things. And so I think this is important as we discuss with our patients as well. You don't have to give up all of the cheese and the yogurt and the eggs and the burgers. Just eat more plants than you do those things. So what would this look like? What's a typical plant-based day? Well, for breakfast, maybe you'd have a whole grain bagel with some apple butter, some veggie bacon, and an apple. Lunch, you could have a whole wheat pita with a spinach salad. Dinner, you could have a tofu and vegetable stir fry with brown rice, maybe some cantaloupe for dessert. And then snacks, all sorts of things, fruits and vegetables and nuts and tortillas and guacamole and salsa. So again, looks pretty good. Looks pretty good to do. So here we have a little bit of recommendations. We have some recommendations from the American Heart Association, from the American Diabetes Association, from the USDA. But again, we are scientists, right? We are researchers. So we don't just take recommendations, whether they're from our associations or whether they're from Beyonce. We want to have some evidence. So let's talk about what the evidence shows in regards to plant-based eating. Looking at weight loss, there was a meta-analysis performed a few years ago which looked specifically at the topic of weight reduction with a vegetarian diet. They analyzed 12 randomized controlled trials containing just over 1,100 participants. So compare this to our previous dietary studies where there were maybe 307 as the maximum number. The median study duration was 18 weeks. And when they looked at the vegetarian diet, they found that those following the vegetarian diet, everything else equal as far as caloric intake, lost about 2 kilograms more than those who were not. And when they did a sub-analysis, they found that people following an entirely plant-based eating plan lost about 2.5 kilograms more. So yes, you can lose weight on a plant-based diet. In cardiovascular risk, again, we have some surrogate risk markers, and there was a multi-centered randomized controlled trial that wanted to look at health outcomes, specifically surrogate markers of cardiovascular risk. There were 291 participants followed for 18 weeks, and they came from all over the country, from the south, from the east, from the north, from the middle of the country. And the intervention group was asked to follow a low-fat vegan diet compared to just regular diet, no dietary counseling, people who were not following this dietary plan. And what they found were that there was a decrease in total cholesterol and a decrease in LDL that were statistically significant. Interestingly, triglycerides went up just a little bit, and HDL went down just a little bit, but LDL definitely decreased. And these were all statistically significant changes. So we have some surrogate data. But interestingly, this is the only dietary plan that we've discussed today that does have some prospective outcomes specifically on cardiovascular events, so heart attacks. The National Health and Nutrition Examination Survey follow-up study was a prospective observational study of just over 9,800 participants. They were followed for 19 years, so a pretty long time. And during this time period, just over 1,700 had some sort of acute ischemic cardiovascular event. There were also 888 strokes during this time period. And when they looked at the nutrition components of the individuals' diets, they found that people eating fruits and vegetables at least 3 times a day, compared with those who were not, had a decreased incidence of ischemic heart disease with a relative risk of 0.85 and a decreased incidence of stroke with a relative risk of 0.61. So the only dietary plan that we have evidence on cardiovascular risk shows that plant-based eating does decrease the incidence of cardiovascular events from ischemia as well as strokes. And what about insulin resistance? You may have noticed in our daily nutrition plan that the plant-based diet was the only one that had a bagel. None of the other eating plans allowed any sorts of bread or pasta or anything like that. So carbs, are they okay for diabetes? Well, this is the only plan that has carbs, so I think looking at the insulin resistance data is pretty important. Just this year in July, a systematic review and meta-analysis was published that looked specifically at the association between plant-based eating and type 2 diabetes. They were able to assess 9 prospective observational studies with just over 307,000 participants. During the time period, they found just over 23,000 new cases of type 2 diabetes, and they found an inverse relationship between a higher amount of plant-based dietary patterns and diabetes. So the more plants the participants ate, the lower their risk of diabetes. And they were able to determine a risk ratio of 0.77. They also looked at the relationship between whether your protein particularly was composed of plant or animal protein. And they found that people who had replaced their animal protein with plant protein also had a lower risk of diabetes with a relative risk of 0.7. So some pretty encouraging data that you can eat carbs and still have a decreased risk of diabetes. And finally, looking at mortality. Remember, the Paleo study did have one prospective observational study looking at mortality, and it was promising. We also have some observational data looking at mortality with plant-based eating. This was also published relatively recently in August of this year, and this is a longitudinal cohort study that looked at the association between animal and plant protein and mortality in general. There were 70,000 participants, so about 3 times as many as in the Paleo mortality study. And they were between the ages of 45 to 74 years old. And these participants had no baseline diagnoses of any of the mortality aspects that they were looking at. So no cancer, no strokes, no ischemic heart disease at baseline. As they followed them, they found that increased plant protein was associated with a lower risk of total and cardiovascular disease mortality with a hazard ratio of 0.84 and 0.89 respectively. And when they substituted plant protein again, they found that if you substitute plant protein for red meat, this was associated with a lower total cancer-related and cardiovascular disease mortality as well, with hazard ratios between 0.58 and 0.66. So pretty strong evidence for plants decreasing mortality. So let's summarize the information that we've discussed so far today, looking at our outcomes of weight loss, cardiovascular risk, insulin resistance and glucose intolerance, and mortality. If you look across the board, there's one that has benefits in all 4 categories. Sure, you can lose weight on any diet plan. There is a little bit of data in regards to surrogate cardiovascular risk markers and insulin resistance and mortality, but I think the one that's present in all categories, regardless of what we're looking for, is a plant-based nutrition plan. So then, which diet is best? Let's go back to our question. And I would submit to you that there is no diet that is best. I would suggest that there is a way of living that includes healthy nutrition that is best. But I would not, based on the data that we have, recommend any particular diet plan as better than any other. When we're talking to our patients who ask us, what diet should I follow? What plan should I follow? I think it's very important to take into account our patients' personal considerations. If we have patients who do not like certain types of foods, that's really important if we're thinking about nutrition plan, because if you do not like something, you are not going to eat it. And so really working and partnering with our patients to talk about nutrition, what sort of foods they like, what sort of foods they don't like, what are they willing to change, what are they not willing to change, and then also keeping in mind our goals for our patients. Sure, we want them to feel good about themselves. We want them to get to be a healthy weight. But the reason for that is because we care about their cardiovascular risk. We care about their risk for diabetes. And we care about their mortality. And so I think sitting down with our patients and partnering with them to develop a way of living that includes healthy nutrition is really the best diet to follow. So summarizing everything that we've talked about today. One of my favorite food authors, Michael Pollan, I think really condenses all of this information into one phrase. He says, eat food, not too much, mostly plants. And the way that I take this is eat food. right? Eat food, not things that have been made in a factory, not things that are so processed that when you look at the nutrition label, you can't pronounce many of the ingredients on the back. So eat food, eat plants, eat grains, eat, if you like proteins, eat meats and cheeses and milks, eat those things, but eat food, eat real food. And not too much. Thinking back to the first law of thermodynamics, the rules, energy in, energy out. Eat your food and don't eat too much of food. Make sure that energy in is less than energy out and weight loss will happen. And finally, mostly plants. Not all plants. You don't have to eliminate ice cream, on a special occasion or maybe every day, but eat mostly plants. Center your nutrition plan around those healthy things, those things that have been shown to improve mortality and cardiovascular disease and insulin resistance. And I think if we follow this ourselves and we recommend it to our patients and our friends and our family members who ask us about our dietary recommendations, we will all live a healthier life and potentially be able to combat the obesity epidemic that we are seeing in our country today. With that, I thank you so much for your attention, and I'll be happy to take any questions that you have. Yeah, thanks so much. So the question was regards to calorie counting and logging nutritional intake and restricting in regards to apps like MyFitnessPal. There has been some data that shows that people who are very regimented about recording their caloric intake do tend to lose weight and keep weight off for longer. There has been a long-term study looking at the National Weight Loss Registry who's followed people who have lost a significant amount of weight over time. And it does show that one of the common factors in those participants is logging. So you're more likely to stick to any sort of a nutrition plan if you're paying attention to what you're doing. So there is some evidence that keeping track of what you eat can be helpful for weight loss. Yeah. So the question was about what is the all-day fat-burning diet, and it's a variant on intermittent fasting, where the man who created it has specific recommendations for not only the pattern, the schedule for intermittent fasting, but also what to eat during the times that you are eating to improve your fat-burning capacity. Yeah, thank you for the question. So the question was about physical activity and the combination with eating patterns. And what we know is that we do burn more calories with exercise. The typical we used to talk about the 70-kilogram man would burn between 200 and 300 calories with 30 minutes of moderate intensity activity. So that's like a peanut butter sandwich. So you can definitely burn additional calories with exercise, but it's really hard to exercise enough to combat the nutrition that you put into your body if you don't limit nutrition as well. People who are training for half marathons, triathlons, people who exercise for several hours a day do need to eat more to compensate for the activity that they're performing, but the typical person who goes to the gym for half an hour a couple of times a week, really, it's not going to result in a significant amount of additional weight loss without calorie restriction. Yeah, so the question is about obligate glucose requirements and whether if there's a certain amount of carbohydrates that is going to keep us from going into ketogenesis. I think thinking back to the slide on energy physiology, we know that you can store about 3,000 calories of glycogen So if you still have those 3,000 calories of glycogen stores, I think you don't need to have a daily glucose requirement. But if you have burned off those 3,000 calories of glycogen, then there may be an obligate requirement that's going to keep someone from going into ketosis. I don't know the specific amount though. So the question is about looking at the percentages of various nutrients on plant-based eating and ketogenic diet and whether it differs. For people who follow any diet other than ketogenic, the carbohydrate content is usually, when they do observational studies, somewhere between 45 and 70% carbohydrates. And that's pretty consistent among all of the dietary groups. So ketogenic is the only one where the carbohydrate content is significantly decreased at the expense of increasing fats and proteins. Yeah, that's a very good question. So the question is about, are there any ways that the basal metabolic rate is modified? Does it change with age? It's mostly determined by genetics, but we do know that women have a slower basal metabolic rate than men. Sorry. And also that your basal metabolic rate does decrease a little bit with age. There is some evidence that if people do weight-bearing activity as they get older, they can combat that decrease in basal metabolic rate, so it doesn't have to decrease with age as much. But if you did nothing, then that would occur. Yes. Yeah, so the question was in regards to the surrogate risk markers, and won't you have an improvement in your lipid profile if you lose a significant amount of weight regardless of what diet you follow? And absolutely, yes. And so what I didn't mention due to time constraints was that they did control the results for BMI, for weight loss, et cetera. So those were the adjusted data when they controlled for those other conflicting factors. But absolutely, yeah, if you lose a bunch of weight, you're going to have better lipids for sure. Thank you.
Okay, thanks so much.
Thanks so much, Dr. Winters. I appreciate it.